management of abdominal tuberculosis. So when to suspect, that is very important. When to suspect the patient is having abdominal tuberculosis is basically what happens, any organ in the abdominal cavity including gut, lumen and peritoneum may be affected. So based on the site affected in abdomen, if it is peritoneum, then the patient will have abdominal distension, pain abdomen and fever. So this can be the presentation. If there is intestinal involvement, the patient may have recurrent intestinal colic, partial incomplete intestinal obstruction, chronic diarrhea, weight loss. There may be palpable abdominal mass, and they can also have a complaint of lower GI bleed. Alright. If somebody is having esophageal involvement, the patient can have dysphagia, odynophagia, hematemesis, constitutional symptoms may be there. In case of gastroduodenal tuberculosis, they present like gastric outlet obstruction and also sometimes GI bleed. In case of perianal involvement, if somebody is having perianal tuberculosis, so this patient typically presents with your simplex to complex perianal fistulas and persistent discharge. That is very important. Okay, and this point is very important, that fistula which recurs after multiple surgery. So if you see in your clinical practice, if some patient is having a recurrent perianal fistulas and that was being treated for multiple surgical operations were done, and after that the fistula is still recurring, it is not healing, so always think of perianal tuberculosis in such patient. All right. In case of pancreatic involvement, abdominal pain may be there, obstructive jaundice may be there, or you can also see dilated pancreatic duct with pancreatic cyst or pancreatic mass. Okay, they may also have a constitutional symptoms. In case of hepatobiliary tuberculosis, typical they can present like your pyrexia of unknown origin, they have a hepatomegaly, they may present your jaundice with elevated alkaline phosphatase, and they can also present your SOL and hepatic abscesses. So that is how, depending on the site where the tuberculosis is affected, in case of abdomen, the typical classical symptoms are presented. All right. So how to evaluate for a case of suspected abdominal tuberculosis? If the patient is having peritoneal tuberculosis, patient present like your ascites. So what you do, as we do in effusion, you do a ascitic tap and look for the cytology. Typical cytology is lymphocytic predominance and absence of malignant cells. All right, and you look for the SAG, that is serum ascitic albumin gradient, that will be typically less than 1.1 gram per day. So that is very important. Also, you can do a culture, you can do a NAT testing, and you can look for the ascitic fluid ADA, that is usually more than 39 or sometimes more than 40 also. That will also help us to diagnose abdominal tuberculosis. Ascitic on imaging, if you do ultrasound imaging, you can see the ascites, you can see the lymph node, you can look for the bowel thickening or for the tissue acquisition for cytology and microbiology. If you find any tissue suspicious there, you can also take sample, ultrasound guided sample, ultrasound guided lymph node aspiration, and you can do a FNSE or cytology also. Okay, if it is accessible by ultrasound. If by doing this, if diagnosis is not clear, although if you do all these things, you can fairly establish the diagnosis, but sometimes if diagnosis is not clear, then you can plan for laparoscopy. Okay. In case of GI tuberculosis, in case of gastrointestinal, you do a imaging, you can do a CT or MR enterography, that is a preferred investigation. And what you can find there, you can get there bowel thickening, strictures, necrotic lymph node. They are very classical in case of tuberculosis. And also you can do a CT chest to look for any lesion in the lungs. You can also do an endoscopy guided biopsies if there is any abnormal area, upper GI endoscopy you do for this, and you can take a biopsy of esophagus, you can do a gastroduodenal biopsies, and you can do ileocolonoscopy. For intestinal TB is mandatory to acquire tissue. For the intestinal tuberculosis, you do a ileocolonoscopy, and if there is any abnormal tissue, you do a biopsy. Okay, and after biopsy, you send the sample for histology, and histology you know that classical cascading granuloma is very specific. So this is, if you do histology and you find cascading granuloma, that establishes your diagnosis for tuberculosis. All right, you can also send this sample for AFB culture and NAT testing, that is CB-NAT. Sometimes barium study is also needed, but nowadays barium study is very limited, and since we have a more of sophisticated investigation in the form of CT/MR enterography, upper GI endoscopy, so barium study is not done very frequently nowadays. All right. So when the CT is unavailable, then we can go for barium study. However, if still diagnosis remains unclear, we can refer this patient for further evaluation, because the patient may have some other diseases. And the important point, differential remains Crohn's disease. That is very important sometimes, because Crohn's disease is a very close diagnosis with your tuberculosis. So sometimes we have to evaluate also Crohn's also sometimes. And in certain situations when there is a resource limited setting, we do not have the proper facility, so we can give a trial of anti-tubercular treatment and with careful follow-up. Fine. In case of perineal tuberculosis, you should remember that is uncommon, and on imaging you can do a MRI pelvis or endoanal ultrasound, and you can attain some tissue, you can get some tissues and then send that tissue for histology and microbiology. And in histology again you have to look for the classical granuloma as we see in case of tuberculosis. In case of pancreatic and hepatobiliary tuberculosis, this point is very important. Malignancy is a more important concern here. You have to think of malignancy first, because that is a more confounding and the more important diagnosis to arrive, and that needs your imaging. Sometimes endoscopic ultrasound guided tissue acquisition is needed. You do a ERCP or do a ultrasound guided biopsy if possible, and if that is not the case, you have the limited facility and you cannot evaluate properly, then you can also send this patient to your higher center for detailed workup. So as remember that malignancy here is more important concern. So how to treat a case of abdominal tuberculosis, that is very important. So as per NTEP, start treatment and follow up as per NTB guidelines, and first line treatment for adult and children with abdominal TB remains your again 6 months of your treatment, anti-tubercular treatment, including 2 months of your HRJD and 4 months of HRE. You can extend the duration. Important point is here you can see extend duration in case of treatment, in case of the patient has inadequate response and you are doing a follow-up scans. So sometimes you can also increase the treatment depending on the clinical response of the patient. And sometimes the patient needs surgical management for the complications like intestinal obstruction that may be due to strictures and due to perforation. So sometimes patient may need your surgical management. So you also take a call, take help of your surgical fellow if patient develops complication on your treatment. And refer to biliary drainage in case of jaundice due to biliary obstruction. So obviously biliary drainage is needed in case of biliary obstruction. Alright, so how to do a follow-up? So one is your definite abdominal TB. Definitive abdominal TB means there is either microbiologically positive or they have a classical caseating granuloma on histology. So if that we call as a definite abdominal tuberculosis. And now we have started this patient on anti-tubercular treatment, that is 2 months of HRJD and 4 months of HRE. Alright. So in all such patients, you do a clinical assessment at 4 and 8 weeks. 4 means after 1 month and after 2 months means end of your first month of your IP and end of your IP. Okay. So what you have to look for? You have to look for the patient have no issue, his fever have been improved, pain is improved, and there is a disappearance of your abdominal distension and patient has gained weight. And you have to also look for the ATD induced hepatotoxicity with serial LFT monitoring. So you have to look LFT also and you have to monitor LFT. Fine. So if you see that patient is improving, so complete the standard treatment. And if there is a no improvement, you can see here, if there is a no improvement at 8 weeks, then refer this patient for evaluation of MDR. This patient can be a MDR TB case because that is very important to exclude. Alright. Fine. Now, what happens in case of clinically diagnosed? You have patient was classically presented with your clinical signs symptoms, and you thought that patient is a case of clinically diagnosed abdominal TB, and you have started him on or her ATT. So that how to follow. So in this case, you have to again follow up the same at a 4 and 8 weeks. Look for the signs, symptoms, weight gain, and if patient has improved, you have to complete ATT, and if not improved, then you have to exclude workup for MDR. Other diagnosis workup is also needed. Okay, and assessment of clinically diagnosed cases in case of peritoneal TB. How to do a peritoneal TB? You do an ultrasound for ascites at 4 to 8 weeks and see for the resolution of ascites. And in case of intestinal TB, you do an ileocolonoscopy at 8 to 12 weeks, means 2 to 3 months, and look for the healing of the lesion. Okay, and at the end of therapy, it is very important, document mucosal healing in colonic and upper GI TB, and imaging in case of small bowel disease to document healing. So you have to, when your treatment is completed, anti-tubercular treatment is completed, you have to look for that mucosa or the lesion has healed by doing appropriate invasive imaging testing.